The Aspetar Hamstring protocol is a best evidence synthesis rehabilitation protocol with criteria-based progression. It was developed to include clinical experience, latest research findings, and patient involvement in a shared decision-making model. The protocol consists of 6 stages, 3 physiotherapy stages and 3 sport-specific stages. An overlap of exercise between the stages is allowed, recognizing the fluidity of the rehabilitation process and reflecting an integrated protocol with set criteria for progression. The main feature of the protocol repeated in each stage is the early but safe resumption of repeated high-speed running and direction change movements. Stage 1. Promote healing and early optimal loading of the injured tissue. The aim is to protect the scar tissue development and minimize muscle atrophy and pain. Stage 2 to 3. Regain full muscle function. Regain full voluntary control over the injured muscle and pain-free hamstring strength, initially in the inner range progressing to longer hamstring lengths. Developed appropriate control of trunk and pelvis with progressive movement speed and increased load on the hamstrings. Pain-free running up to maximal speed is also included, with changes in direction performed under fatigue. Stage 4 to 6. Integrated full sport-specific participation. The aim is for the player to be symptom-free during all activities and complete 3 progressive sport-specific sessions with no pain at the time of exercise or after, and to display full maximal effort during each session. The patient is seen for the primary evaluation, which includes clinical diagnosis as well as MRI report if such investigations were performed. It is recommended that rehabilitation is initiated as soon as possible for the patient, without unnecessary delay. The mechanism of injury, as well as specific details of the functional levels immediately post-injury, are also recorded, including mobility, walking level, and pain. The patient is also questioned regarding exposure to training and match load. Modified numeric rating scale. The patient reports the intensity of maximal pain at the time of the injury and the average pain for today using a modified numeric rating scale ranging from 0 to 10, where 0 reflects no pain and 10 reflects severe pain. Gait. The ability to walk and jog without pain or antalgic patterns are noted. If the athlete is using crutches, then this is documented. Standing trunk flexion. The patient is standing in an upright position with knees extended. The patient is instructed to progressively flex his trunk with arms or hands always touching the legs towards the level where he is incapable to flex further. The range of trunk flexion is noted as the finger touch level, knees, mid-shins, ankles or floor, and the patient is asked whether it is pain from the injured area or a general stretching pain that prevents him from flexing further. Two-leg squat. The patient is standing with his hands on his hips and the feet shoulder-width apart, the thighs against the bench and the bench at a height equal to the knee joint line. The patient is asked to lower his body by bending his knees until he touches the bench, while the upper body is maintained in an upright position. Single leg squat. The patient is standing with the feet shoulder width apart, with the thighs towards the end of the bench at a height equal to the mid-thigh, with the hands on the hips. The patient is asked to lower his body by bending his knee until he touches the bench, while the knee is directly in a line above his foot. Palpation. The patient is lying on the examination table in a prone, relaxed position with both knees extended. The patient is instructed to indicate whenever the palpation provokes pain and which point is the most painful. The total length, width, and the distance between the ischial tuberosity and the area with maximal pain are measured in centimeters. Passive straight leg raise test. The patient is lying supine while the clinician is fixating the untested leg. The patient is instructed to relax and report whenever he feels any pain in the injured area or a maximal stretching pain towards the end of the movement. Using a handheld inclinometer placed on the mid-anterior border of the tibia, the clinician passively raises the patient's leg, ensuring full knee extension, and the angle at the end point is measured. Passive knee extension test. The patient is lying supine with the hip and knee of the tested leg flexed to 90 degrees and the contralateral leg remaining extended on the examination table, fixated by the clinician. The patient is instructed to report if he feels any pain in the injured area or a maximal stretch towards the end of the movement. The clinician supports the tested leg with his foot, ensuring 90 degrees of knee flexion. Using the handheld inclinometer on the anterior tibial border, the examiner gradually extends the knee to the point of resistance, where no further knee extension is possible, or the point where the patient reports pain or the onset of discomfort. Maximal hip flexion active knee extension test. The patient is lying supine and instructed to move his hip towards maximal hip flexion, with his arms pulling around his thigh towards his chest. From this starting position, the patient is instructed to actively extend the knee until reaching the point of pain or maximal tolerable stretch in the hamstring muscle. The absolute knee extension angle is measured with the handheld inclinometer placed on the anterior tibial border of the leg. Strength measurement. 3 maximal contractions with only a short rest period between each contraction are performed. The patient is instructed to push as hard as possible within their pain-free limit and to report any feeling of pain or discomfort from the site of the injury. If they are unable to perform the test without pain, the test is terminated immediately. Isometric inner range strength test. The patient is lying prone with the knee of the tested leg actively flexed to 90 degrees, while the contralateral leg remains flat. The clinician is standing behind the patient at the end of the examination table, holding the handheld dynamometer horizontally with both arms against the patient's posterior heel. The patient is asked to actively perform maximal isometric knee flexion for 3 seconds, and these standardized instructions are given. Strength measurement. 3 maximal contractions with only a short rest period between each contraction are performed. The patient is instructed to push as hard as possible within their pain-free limit and to report any feeling of pain or discomfort from the site of the injury. If they are unable to perform the test without pain, the test is terminated immediately. Eccentric mid-range strength test. The patient is lying prone and the clinician passively flexes the patient's knee to 1 foot distance above the examination table. The clinician is standing behind the patient, holding the handheld dynamometer with both arms against the patient's posterior heel. The patient is instructed to perform maximal isometric knee flexion for 3 seconds, after which the clinician applies an eccentric brake test. Strength measurement. 3 maximal contractions with only a short rest period between each contraction are performed. The patient is instructed to push as hard as possible within their pain-free limit and to report any feeling of pain or discomfort from the site of the injury. If they are unable to perform the test without pain, the test is terminated immediately. Eccentric outer range strength test. The patient is lying in supine while the pelvis and contralateral leg is fixated by a belt. The clinician passively moves the patient's leg to 90 degrees knee flexion. While sitting or standing at the side of the examination table, the clinician is holding the handheld dynamometer with both arms and keeping it vertically against the patient's posterior heel. The patient is asked to actively perform a maximal isometric knee flexion for 3 seconds, after which an eccentric brake test is applied by the clinician. These standardized instructions are given. Double to single leg bridge test. The patient is lying in supine with the arms in a comfortable position. Both feet are placed flat on the examination table. To reach the starting position, one knee is flexed and placed beside the medial knee joint line of the other leg, which is then placed similarly, leaving both knees flexed at approximately 90 degrees. The patient is instructed to perform 3 repetitions of hip extension, where he pushes down through the heels and lifts the hips off the ground towards full hip extension. Completion of 3 pain-free repetitions on both legs in stage 3 progresses the patient to stage 4. The patient is instructed to raise his untested leg off the examination table and then perform 3 repetitions, where he pushes down through the heel of the tested leg and lifts the hips off the table towards full hip extension. Completion of 3 pain-free repetitions on both legs in stage 4 progresses the patient to stage 5. The patient is instructed to perform 3 repetitions of hip extension while keeping his tested leg extended and supported on the clinician's shoulder while pushing down to the posterior distal part of the calf and lifting the hips off the table towards full hip extension. The untested leg remains off the examination table. Isokinetic muscle strength testing. The patient is seated upright in the dynamometer chair, stabilized with chest, hip and thigh straps, and instructed to grip the chair handles throughout the test. The axis of knee rotation is aligned linear to the lateral femoral condyle, and gravitational correction is performed at 30 degrees of knee flexion. During the test, the patient is given vigorous verbal encouragement to exert maximal force throughout. Dynamic flexibility H test. The patient is lying supine with the contralateral leg and the upper body fixed with a strap. On the tested leg, a brace ensures full knee extension at 0 degrees. The foot of the injured leg is kept in a slightly plantar flex position. The H test begins with the passive flexibility test, where the clinician slowly raises the tested leg towards maximal hip flexion. The patient is instructed to relax and say stop when the movement reaches the maximal range of motion. The patient is firstly instructed to perform the practice straight leg trial with submaximal effort, followed by the 3 active test trials, where the patient is instructed to perform a straight leg race as fast as possible to the highest point without taking any risk. Eccentric strength test with the NORBOARD. The patient is kneeling on the NORBOARD with the ankles placed in the hooks attached to the load cells measuring the force. The patient is instructed to perform 3 repetitions with maximal effort. From the upright kneeling position, the patient is instructed to fall forwards while resisting the fall for as long as possible using the hamstring muscles. A minor pause is allowed between each repetition. The average and peak force are registered. Double leg squat to 90 degrees. The player is standing with hands on hips, feet shoulder width apart and with the knees slightly bent. With the trunk kept upright, the player is asked to lower his body by bending his knees to approximately 90 degrees, while the knees are directly aligned above the feet. Exercise bike. In the first treatment session, the player starts at 50 watts for 30 seconds. Thereafter he increases the power by 20 watts every 30 seconds until he reaches the highest level he can cycle at for 5 minutes continuously. We aim for the player to maintain a power output that is equal to double his body weight. Double leg supine bridge. The player is lying in supine in a comfortable position. Both feet are placed flat and both knees in a flexed position. The knee flexion angle may be altered, but placing the foot of one leg next to the knee of the other extended leg can be used to determine the starting position. Supine isometric heel digs. The player is lying in supine with the knees flexed at an angle of approximately 90 degrees. The player is instructed to push down through the heel by activating the hamstrings and hold the position for approximately 5 seconds. The range in which the movement is performed can be adjusted to progress the exercise. Single leg squat to 45 degrees. The player is standing hands on hips on the injured leg with the uninjured leg slightly bent. The player is instructed to lower the body in a squatting position by bending his knees to approximately 45 degrees, while the knee of the standing leg is directly aligned above the foot. Manual resisted hamstring exercise. The player is lying in a prone position with the knees flexed, while the clinician applies isometric resistance in varying angles. The player is instructed to push against the clinician's hand, which is placed on the posterior heel. Progression of this exercise is performed with the player in supine and the hips flexed. Manual resistance is applied towards the end of the movement in an eccentric fashion. Soft tissue mobilization. The player is lying in a prone position. Effleurages are performed distal and proximal to the injured site of the muscle. The patient is instructed to relax and report if he feels any pain or discomfort during the treatment. In stage 2, massage of the injured area is allowed. Active range of motion. The player is lying in a prone position with both legs extended. He is instructed to actively flex the knee of the injured side until the heel touches the buttock or as far as possible without pain, and then slowly extend the knee towards a straight leg position again. Lengthening exercises as described by Askling. The extender. The player is lying in supine, holding the thigh of the injured leg with the hip flexed to approximately 90 degrees. The player is instructed to perform slow knee extensions to a point just before pain is felt. Lengthening exercises as described by Askling. The diver or Arabesque. The player is standing with his full weight on the injured leg with the opposite knee slightly flexed. The hips are extended and the hands are kept close to the chest. The player is instructed to perform the exercise as a simulated dive, keeping the standing injured leg straight while simultaneously stretching the arms forward and keeping the pelvis horizontal. 10 to 20 degrees of knee flexion is maintained while attempting a maximal effort. Lengthening exercises as described by Askling. The glider. The exercise is started with the patient in an upright position, hands placed on a supporting bar and with the legs slightly split. All the body weight should be on the heel of the injured leg while maintaining 10 to 20 degrees of knee flexion. The player is instructed to perform a gliding movement backwards on the other leg and stop the movement before pain is reached on the injured leg. The movement back to the starting position should be performed by the help of both arms, not using the injured leg. Single leg supine bridge. The player is lying in supine with the arms placed in a comfortable position. The player is instructed to push down through the heel of the injured leg to lift the body off the table into maximal hip extension. Stretching. The player is lying in a supine position and instructed to relax as the clinician performs a gentle stretch with the leg in a straight leg position. The clinician aims to achieve maximal hip flexion while maintaining the knee in an extended position. Resisted hamstrings prone leg curl. The player is lying in a prone position on the leg curl machine. Make sure that the length of the lever arms are adjusted to the player's leg length. The player is instructed to perform slow continuous knee flexion and extension movements with the injured leg, starting at a load that is acceptable and pain-free. Eccentric strengthening with the Nordic hamstring exercise. The player is kneeling on the NORBOARD with the ankles fixed or on a mat with the clinician fixing the ankles. The player is instructed to fall forwards, resisting the fall as long as possible using their hamstring muscles. Running progression. Before the running progression commences, the player performs warm-up exercises. These include the triple extension walks with high knee lifts, as well as A drills, where the player flexes and then drags the leg down in a fast circular motion. The running progression program includes volume, intensity, and the observation of running mechanics. It is performed under the supervision of the clinician to facilitate that these components are executed well and any necessary adjustments can be made. When the player starts with the running progression, he is asked to rate the running from the very first lap. 0% would represent the slowest speed at which he could run, and 100% the maximal sprint speed. Each lap is also timed using a handheld stopwatch. Both the percentage rated by the player as well as the timed run is recorded to allow for gradual progression of the running. During each session, the player is allowed to progress by 5 to 10%. Modified T-drill. In stage 3, when the player can run at more than 70% self-rated, a modified T-drill is included. The player is asked to run to each of the cones continuously in a forward motion while changing direction. No sideways or backwards running is allowed. The time of the drill is recorded and used as progression by increasing the speed at which the exercise is performed.